Well, yes. Thank you, Hannes, and good afternoon, everybody. It's my great pleasure to be here back in Berlin. 2017, we were intended to do the first Venus P here, and I was lucky to join that at that time with Sheck at our sides, and so this photo is from that time. And after that, I was traveling a little and moved over to a smaller city in Germany, which is just westwards. And I was happy to see that even yesterday, Berlin stays as an incubator of innovation. So yesterday they went the new Venus P valves in as CE certification. So I was happy to see that, and I was lucky to be here. So thank you for the invitation, and my pleasure. So. Overall, I have to talk about nearly 20 years of balloon expandable pulmonary valve implantation, which is a really big topic, I think, because in the world of congenital, I think it's a really innovation which was done and which helps us, or even helped us in the last years to treat a lot of patients. But nevertheless, it's not that experience which we have in the TAVI still. So I focused on those two valve types, which are those which can be implanted with balloons. This is the Sapien valve, which is several generations, and which is the Melody valve, which was mostly known to everybody. And we have the new generation on the other side. So this was developed in 2000, and I think everybody knows that Philip Bonhoeffer was doing that. And it went into a medical product, which is nowadays, I think, which is not normality anymore. So we heard that in the morning already. And then at that time, we see over here that the implantation numbers are slowly growing over time. And at 2006, with CE certification, we had around 100 implants. And at that time, the program most likely started in several clinics and can be continued until that time of FDA approval. And then you can see that the numbers of implants worldwide, these are the numbers of implants worldwide, are going up with the United States market, where they released this valve there and are reaching around 18,000 implants worldwide now. So the question would be, what is the experience? I come to that later. Overall, we have now in several clinics more than 10 years, I think, more than 15 years somehow. So that is the experience which we have, which is, I think, enough to decide about if this is the therapy we can offer our patients at all. With the Sapien valve, it was a little later on. We see the CE mark in 2010, and then the numbers also most likely are, for me, not known, because then we had several developments with the Sapien pulmonic valve to the XT valve, and then we got to the S3 valve because of the TAVI market. And we had different developments also on the implantation system. Overall, I just roughly estimated around 5,000 valves in pulmonic position, which I'm not sure if this is really the case. But this is no relation to TAVI, which is around 800 Sapien valves worldwide until now, and it's roughly around 60,000 a year. So we are most likely a little forgotten world, but nevertheless, I think it's important work what we do, and we should continue on that, and maybe also use innovations. So loading and crimping of the valve is one on the left side is a Melody valve. It's a hand work, it's a finger work which we do. We crimp the valve on the balloon, and then we can introduce that in a protected sheet in the patient. On the other side, we have crimping machines with the Sapien valve, which we are using, and I think the effect is the same. Put this valve with a stent on the balloon, make it as thin as possible to pass through the sheet, and then implant it at the position where we wanted to have it. We have different sizes, and you can see here that this is, I think, the normal valve, that we have a pre-stent inside, and in this pre-stent then we implant a valve there. I mean, in the meantime, I think several centers may sometimes skip the pre-stent, or sometimes they already implant both together, but this, I think, is a rare condition. We normally, I think, do it after that steps with the pre-stent. So what do we have as sizes? So as you can see here, the valves are somehow not everybody is available already. So we have the Melody valve, which is reaching, I think, within 16 to 24 millimeters of diameter on the RVOT or the conduit. Then we have the Sapien valve, goes up to around 30 millimeters of rev diameter. And then we have the other valves like Pulsar, which is in the pipeline also. There's on CE mark, the study is done, patients has to be follow-up now. And we have newer one, but the talks will later focus on that, the venous P valve, which also goes a little over the 30 millimeters up to 34 millimeters. So with these patients, still we don't have the bigger ones, the Harmony and the Altera. We can most likely treat a lot of our patients, maybe not all. So the normal adult pulmonary valve would be around 23, around 24 maybe, and there are somehow changes according to height and weight and all the things and cardiac output maybe, but that's the normal range where we have to maybe treat our patients. But it's different in the fallow patient. The fallow patient can have RVUT up to 30 millimeters, so that's why we need additional valves as we had with the balloon expandable valves. What is the indication and what is the benefit for the patient? So this is our goal, to achieve a reduction of right ventricular pressure load, which is according to the pulmonary valve stenosis or conduit stenosis. Also improvement of regurgitation fraction, because we wanted to relieve the regurgitation and also the right ventricle diastolic, or even the dimension of volume load on the right ventricle, so the right ventricle volume, which can be measured there. We have to also look for the clinical status. Some of those patients are even symptomatic with the pulmonary regurgitation or with the pulmonary stenosis or conduit stenosis. So overall, we talk about improvement of symptoms and also improvement of measurements like right ventricular volumes and right ventricular function. Initial, so the melody was intended to improve the lifespan of the conduit for nearly a lifetime more than 2 years. That is the initial approach. So Philip Bonhoeffer told us in 2017 why they were choosing this, because of the legal issues. And I think it's somehow different now. We can talk about like a little longer, even not a little longer, even more longer in the behavior and if the durability of the valve. So we can talk about to our patient, I think, about 5 to 10 years as minimum, but that's what the life expectancy of the valve is. Overall, we can also talk about a new valve in this valve, so we can even prolong that period of valvular function in this patient. The indications, according to the IFU, is a gradient above 35 millimeters of mercury, or even a moderate regurgitation if the patient most likely has no symptoms. And in the sapien valve, we can also treat a compliant RVUT, which is somehow difficult sometimes to define, but that's the possibility. In the symptomatic patient, we have lower thresholds for the pulmonary valve stenosis or conduit stenosis. It's 60 millimeters of mercury on the right ventricular pressure, also moderate PR. In the asymptomatic, we go a little higher, but always we look for the trend of that, of the RV function, of symptoms, of indication of pressure load in the ventricle, like arrhythmia, or even a reduction of exercise intolerance. So that's all symptoms what we look for, and that's all arguments. For PR only without stenosis, I think it's different. We really have to look for what the patient's needs are and if he's symptomatic, but overall we have cutoffs for the right ventricular and diastolic indexed volume. It's around 150 to 160, somehow a little higher, somehow a little lower, and I think it's not something which we completely rely on. If there is a steal, or if there is a clear trend and right ventricular volume increase, I think also that cutoffs maybe sometimes has not to be achieved. What is our learning curve? So in 2017, Philip Bonhoeffer told us what have we learned and what have I learned. I think that's huge what we learned over that time, because we, I think, improved that method, what we had in our hands, in order to reduce complications and to increase safety. And so overall, we had procedure-related complications, which we know from the beginning, and we had most likely device-related complications. And all of those can be most likely also improved, means improvement for the patient and the therapy of the patient. So, as you can see on the left side, procedure-related complications, I think really rare, but still can happen. And device-related complications, I think, also can be really reduced or have been reduced in the past, and even can be even better reduced still. So, this is one of the complications which we learned of. Conduit rupture can happen, I think, in every of those calcified conduit which you can see here. It can happen that you completely, at a certain point, overstress that conduit, and it can have a tear, and you can see on the lateral here, a tear to the back, even if the valve is inside. So that can be prevented by covered stenting. I mean, that's something which we have learned, and that's why we sometimes protectively covered stent those conduits with the whole length before we place a valve or something, or even expand that conduit. Another one is like slightly slower. It's like a dissection or even a small tear. Even also of those which we see in the not heavily calcified conduits, we can deal with that also with covered stents, I think. And we can even prevent surgery in those patients where we were not related, where this was not related, most likely maybe to the procedure at all, but we had seen that or have seen that. Coronary compression, also I think a big issue, but this is also a really rare complication already. So this happened, I think, in the beginning as we sorted out that this has to be really carefully evaluated. And if you carefully evaluate that, then you can most likely prevent that complication. And carefully prevention means that you completely check this patient. So I think it's running. If there's a possibility by expansion of the conduit that you compress the coronaries. And if you can see that by ballooning first, where you don't put a metal in there which holds the space which you have to achieve, then most likely it's a reversible complication and it's a reversible compression. So otherwise we used, as you can see below, that is after the balloon, it completely recovered the coronary flow. We can use a lot of 3D imaging for sorting out that complication. And I think that's a preventive strategy and that works in most of the centers. I think it's a really rare complication now. It's not the left only, it's also the right coronary artery you can see here. So check both and you most likely have a safe pathway. Dislocation of the stents of the valve, yeah, that can happen especially in the really enlarged RVOTs and the enlarged conduits. But also I think it's rare because we know about that and most likely we have developed techniques over time that we can prevent that. Interaction also with the aortic valve can happen, so that should be checked if the space between the sternum is really not that much, so all the pressure goes backwards to most likely maybe also in the aortic patient. And there's a specific risk like in the TGA patient where we can also interfere with the aortic valve, and that's a way not to do that valve implantation in those patients. Stent fractures, Johannes did it in the beginning as they did a research project and a publication on that, I think, was also prevented by reducing it by pre-stenting, enough expansion of the pre-stent before the valve goes in, and also maybe also other stent combinations in regard to reduce the recoil and the force against that stents. We have also learned that imaging can tell us something, so pre-decision I think is really important in the valve patients, so you have good, clear picture of the anatomy and you can better decide on your strategy also in the cath lab before. Then we had that big issue of endocarditis. I will skip that point here a little and come to that a little later, not really later, but a little later. Because if we talk about evidence and experience, what do we have already? So evidence and experiencing started with several single-center studies where they compared there maybe some historically or some achieved cohorts over time and thought about they can report about safety, efficacy, and also complications of patients. But these were single-center studies, somehow reaching a follow-up of 2 or 4 or 5 or 10 years, most likely in the meantime, but single-center studies. All had of those some good results. But the complication also have to be issued, and there has to be a strategy to prevent that complication also. So over time, then, multi-center approaches were brought up, and especially with the Melody Registry, it was mostly institutionalized that we have a multi-center approach to look for that problems and also for the performance, maybe also minimum of 12 months. And with that, we saw that reintervention is 14 around something %, and it's also repeated TVP, so it's a valve and valve implantation in 5.6. And endocarditis in 50 patients out of this cohort of 845 patients. So overall, we saw that there's a risk and already identified that residual gradient, but the patient also itself makes an important factor on that complication of endocarditis specifically. So then we shared more data and more multi-center data will come up. So this is a big center group, a big multi-center cohort. It is achieved from 15 centers all over the world, some of Europe, some of United States, all had experience. So in the median, the patient treated in the center were 170 around. So 2,467 patients, were divided by 2,000 around melodies and around 400 40 of sapien in this group. And again, we asked the same question, what is the comparison of the valve? Because we don't have a prospective randomized trial. We don't have that. So that's why we looked on that retrospectively. And because even with the follow-up of 3 years, we see in this patient that the relationship of experience is different in those groups. So we have a lot of more patient years per melody than with sapien. Overall, survival was good, 89% over time. 95 patients died. And endocarditis was 12.6%, around 13% of that. So 12 patients around. But mortality was related to age. You can see that the younger groups are surviving much better than the older groups. And if you look for the classification of reasons why the patients were dying, that is, some of them are cardiac and some of them are not cardiac. So overall, the performance of the valve in the patient, depending on age and all the other issues, surgical procedures before, were really good. So at the incidence rate of 2.4 for the melody and 0.8 for the sapien valve, the comparison can be done by numbers. But if we look deeper in what is the risk factors out of that and what are maybe the factors influencing that, we can see that endocarditis is a rare complication on this patient group, but it depends over time and it is increasing over time. But then we can see that the Staph aureus also is more severe than the viridans or the streptococcus endocarditis. And the treatment is somehow different. Somehow the patients get, or the valves get explanted, somehow the patients get just a medical treatment. But we wanted to see if the valve itself increases the risk for endocarditis, as it was also described by several studies for sapien studies or sapien valve. And on the multifactorial and on the univariate analysis, we saw that there are several factors influencing the risk of endocarditis, but not the valve type itself. So this is the main message out of that paper, that age and residual gradient and previous endocarditis, all that are risk factors for endocarditis, but not the valve itself. Still, we are comparing 1.5 to 4.5 of valve types. So it's a rare condition and it's a rare complication, but it can happen. Then we had also looked and did study group for reintervention and survival. We can see that some of the valves explanted over time, so it's around 258 reinterventions, where some of them are surgery. You can see on the side here that the majority of valves explanted in this patient group are endocarditis types, and then we can see over here that the patient group also got reinterventions from different reasons. So overall, it was a redilatation and valve implantation. And again, the risk for reintervention was the age, because, I mean, the patient they are young, they get their first valve. The immediate post-RVOT gradient, so the post-implant gradient is really important. Keep them as low as possible. And then you can be most likely include or increase your lifetime expectancy of the valve. Overall, freedom from reintervention, transcatheter reintervention was 92% at 5 years, which I think it's achievable and it's a good goal. So what is the perspective? I'm not sure. In the moment, we have those two valves available. Now we see there are coming up new valves. Those without self-expanding may let us treat bigger RVOTs, let us treat different patients maybe where we may be a little reluctant in the past. But we will see, and we will see what's happening to the numbers and also the patient treated. For me, there's another perspective coming up and making us a little more thinking of that. So what is happening to us in our interventional tools, which we have already, if we can have those valve nows, and we have them because they are most likely certified, they can also continue, but we don't have the material to bring those valves in, like stents, like bib balloons, like sheets, like all the big sheets we need for that. So I think that's maybe a question which should be addressed in the future. I hope we get an answer to that and we can continue with that. But we already have shown all that this valve implantation is a really good therapy for the patient. So thank you very much.